Next, we move on to the next speaker, Dr. Anil Radhakrishnan. He is a classmate of mine. He is known to most of the KSOS members. He is senior consultant in Amrita Institute of Medical Sciences. He's heading the Department of Cornea and Refractive Surgery. The topic is Diagnostic Dilemma, Infectious Scleritis Challenges.
Yeah, thank you, Anabi. Can we have the slides, please? So scleritis is a topic which we used to skip during our PG time. I think no questions will come from this. We'll skip to something else and study something more. But that's not the case in real life. Scleritis, as Dahlia has mentioned now, can you go to the slides, please? As mentioned now, I think it can come with a variety of manifestations and it can be visually debilitating to a lot of people. I will take you through a few cases of infectious scleritis. This 42-year-old teacher came with eye pain and red eye, loss of vision and discharge of 1 week duration. She was a known case of vaginous granulomatosis, CANCA, PANCA multiple times positive, was on methotrexate, had taken 10 cycles of cyclophosphamide, 2 doses of rituximab, but continued to have scleritis and recurrent hemoptysis and nasal discharge. So the ophthalmologist there had done 3 amniotic membrane transplants to basically with a diagnosis of non-infectious or immune scleritis. So on examination, her vision was PR accurate. That is the picture that you see. I think the area of scleral necrosis and was even more than the size, double the size of cornea. In fact, actually, the almost half the sclera was involved with this. And when you open the eyes, you can feel the stench, like seeing a diabetic foot ulcer. You know, the smell will come. So, in addition, she had multiple peripheral corneal infiltrates, mainly in the posterior stroma. AC inflammation AC was a bit shallow, and multiple posterior synechiae were present. And B scan showed disorganized globe with choroidal thickening. So blood workup showed prominent leukocytosis, high inflammatory parameters ESR and CRP. Anti-PR3 antibodies were very high, more than 100, suggestive of a relapse of a vaginous granulomatosis. So the diagnosis was again necrotic scleritis with secondary infection and a lot of other complications along with the UTI. So how do we treat this patient? So I think it's very important that I think it is not your cup of tea. I think it's a rheumatologist who must be the primary caregiver. You are only helping with the conjunctival part. You know, the vaginous granulomatosis, if you leave the patient without any treatment, the average lifespan is about 18 months. It's a very severe disease. So now situation has changed quite a bit, but without proper immunotherapy or what your cyclophosphamide and other stuff, the lifespan is severely affected. So we did a scraping from the inflamed scleral bed, which showed both grams, KOH and AFB was sent. And all were negative. Those showed a lot of pus. We started on IV vancomycin and cefeprazone to cover both. Culture came after 2 days with a lot of gram-positive bacilli and coagulase-negative staph. Luckily, both were sensitive to gatifloxacin. So after just 2 weeks of systemic plus topical antibiotics, her scleritis settled down significantly, but the eye tended to remain red. So that was because of increasing this PUK as well as the immune component of scleritis. So in addition, she had worsening sinusitis and HRCT showed just multiple nodules. So the dilemma for the rheumatologist basically was whether to immunosuppress or not. But I think he took the call and he gave IV methylprednisolone along with oral cyclophosphamide. And over a period of time, the eye settled down. But because of the inflammation, the eye started getting disorganized and it was getting pre-thisical. So I did a large patch graft. I don't have the time to show the details. But with a large patch graft, her globe could be saved. And there was some semblance of normalcy to the globe. And still the globe was small, but the vision was about CF 1 meter. And it could be maintained. So you might ask me, why didn't you enucleate the patient? So the rheumatologist was telling that if you take away the sclera, it might attack the other sclera. That is the reason why we retain the globe. So this is pre-treatment and post-treatment. Another representative example, a 47-year-old lady with no comorbidities, with a history of recurrent pain and redness for the 4 months. She was treated as nodular scleritis, started on systemic and topical steroids. 3 doses of cyclophosphamide was given from another multi-speciality hospital. At the time of presentation, he was taking Visalon, Defluomide, methotrexate, and folinic acid. So what you could see was multiple nodules in the sclera projecting out like this, but there was no pus, there was no epithelial defect. You see the fluorescent staining over there, absolutely no staining. But if you ask the patient look up, you can see that the sclera is very thin all around. So again, our dilemma was whether it is infective or immune scleritis. So we did the rheumatology workup. Everything sort of came out negative other than some bottle elevation of CRP and DSR. So we went ahead with an excision biopsy. We sent it for histopathology as well as microbiological study. And we started on basically a broad spectrum, IV vancomycin and amic acid was given. So we did the gene expert to rule out tuberculosis. The AFB also was looked into, all were negative. The patient improved symptomatically and regression of the nodule was seen. So this happened, like she was admitted for about 2 weeks and then discharged. Follow-up at 1 month showed another nodule there, which again we did a scleral debridement. So whenever you see such patients, you have to open up the sclera, just like the diabetic foot ulcer, you have to keep it open. Usually underneath the sclera there will be pus. So you have to really make it open and then only it will heal properly. So after 3 debridements, her eyes looked settled, vision came to 618. And at 3 months follow-up, she was asymptomatic. That area of scleritis you see still the choroidal show, but eye was asymptomatic. She's still under follow-up. So infectious scleritis is something you have to be really, really scared of. So the one prominent thing that is present in infectious scleritis is pain. There is quite often a history of trauma, which causes some foreign body or something which gets into the eye. As the previous speaker was mentioning, sclera is an avascular tissue and it is not a metabolically very active tissue. So if the sclera gets injured, there is a chance of these organisms growing up there. So there is notorious, pterygium surgery with mitomycin is notorious for you to get scleritis. Then systemic immunosuppression, HIV, diabetes mellitus. In varicella zoster, HSV and all that, you get the granulomatous type of scleritis. It's not exactly because of the organism itself, it's an immune reaction to it. So there are 2 ways in which infectious scleritis can happen. Direct invasion, which is more dangerous. Like the 2 cases I showed that were both direct invasions. So in tuberculosis, varicella zoster, and sometimes in acanthamoeba, you get this granulomatous reaction in which you have to give steroids also. That is an inflammatory reaction to the infective antigens that are there. So this is a patient with Pseudomonas keratitis. There was a limbal involvement, then the sclera was involved. So infectious disease, if you look at the amount of scleritis, if you look at larger meta-analysis, we see that about 10% contribute to the infectious scleritis, while in India it is slightly higher, it is about 18%, that is from a large series. So among the organisms, the notorious stuff like Pseudomonas and Mycobacteria are known to cause infectious scleritis. So it will cause a nodule with pus and conjunctival ulceration, and pain is something very characteristic. In contrast, non-infectious has a purplish flu, and it does not look so much very inflamed. So the patient does not come to you with a diagnosis of infective or non-infective scleritis. Quite often, it is a big diagnostic dilemma. And whenever you have a doubt, you have to do a biopsy. And when you do a biopsy, you have to send for microbiology as well as histopathology. And histopathology is also helpful. Necrosis is seen in infection. In fibrinoid necrosis and occlusive vasculitis is seen in necrotic scleritis. In some of the cases of like in infectious scleritis, quite often the infiltrate that you see is neutrophilic, while in others it is mainly lymphocytic. So it can give you some clues. So I'll wind up showing this particular man who had a great diagnosis but had a very bad visual outcome. The 70-year-old man with CKD, came to the OPD in a wheelchair, unable to sit. He was disabled by pain even though his vision was 618. So he had a history of trauma while cutting the wood. Some piece went into the eye, which was removed, and sutures were put. So we did as expected, we did a scraping. Even the sutures we sent for a microbiological study. So the patient was actually quite sick and was admitted for stabilization. So once we did a rheumatology workup meanwhile also, and there was definite neutrophilia. And while he was admitted, we first found that the scleritis was worsening. So debridement and biopsy was done. And when you debride it, we see that underneath lot of areas, sclera is really melting away. And this is very notoriously, very commonly seen in infectious scleritis, and it's very important to remove all that. We found that it is a peculiar fungus called Exophilia gianselmi. So it is a pigmented septate fungi. So the drug of choice is voriconazole. We gave IV voriconazole. We gave fortified voriconazole preparation and natamycin, but it went on to worsen. And at the end of 3 weeks, the patient himself told me he wants the eye to be out of the body. He cannot bear the pain anymore. So at about 3 weeks, we desperately did a enucleation for this particular patient. So quite often, infectious scleritis behaves very notoriously, and the outcome is bad. So that does not mean that we cannot treat it. In quite a few situations, we'll be able to salvage the vision and quite often the life of the